This is Dennis Kim talking to you from the SCAI conference in 2011 in Baltimore. Today we have the pleasure of having Dr. John Cheatham at Nationwide Children's Hospital, who just gave the keynote lecture for the Mullins keynote lecture with a talk describing past, present, and future hybrid therapies. Thanks for joining us, John.
Thanks, Dennis.
So, John, you've been a fantastic leader in this field for quite some time, and I think that the things that you talked about were really exciting, sort of things that were exciting in the past and as well as in the future. How did you get started in all of this?
Yeah, it's a good question. I think that it was an honor, first of all, to speak at the lecture named for Chuck Mullins, who is a mentor for most of us in interventional cardiology all over the world. And one of the things that Chuck taught all of us at that time was to be creative and innovative. It happened to be a long time ago that we had our training, but nonetheless, the things that we were taught by Chuck seemed far-fetched at the time. And so one of the challenges that we have modern day is that we still have so many complicated problems to deal with in cardiovascular disease, and particularly congenital heart disease. And it just became apparent that just one specialty couldn't do it all. The surgeons were doing a terrific job in the operating room for congenital heart disease. I think that we were doing an excellent job in the interventional laboratory and the cath labs to treat children and adults with congenital heart disease. But we both faced challenges that were not easy to overcome. And it became more apparent as we talked with each other more and worked with each other more as disciplines that there were times when we could work together at the same time, both using each of our skill sets, and be able to treat patients more effectively and eliminate some of the obstacles that we both have during our standard treatment. So we coined the term hybrid. I'm an Oklahoma boy, so hybrid. I know about hybrid wheat and hybrid this and crops, and now hybrid's everything. Hybrid cars, hybrid energy, hybrid everything. So we coined that term only because it's a blending. It's a mixture.
The relationship between you and Mark Landwitz has been a very special one. A lot of places will say, "Well, I want to develop a hybrid program." What are some of the things that has made your relationship pretty special and constructive and innovative?
I think that people come a lot and talk about, we'd like to do this at our institution, but where do you see the major obstacles? How can you overcome them, and what are they? And so one of the first things that I found is that you have to have individuals on all sides of the fence that are willing to listen to each other. Mm-hmm. That's first. One of the things, though, in our modern-day society, and it's worldwide, is sometimes surgeons and cardiologists, particularly interventional cardiologists, are in competition with each other. Mm-hmm. We're at odds. We're competing for the same patient to do a procedure, either in the operating room or a cath lab. And so one of the things that we quickly learned was you have to eliminate that competition. Mm-hmm. You have to take it away. So one of the things that Mark and I did from the very start was, we need to work together, but it shouldn't make any difference who does this. And if we both do it, that's even better. Mm-hmm. But money you got to get finances out of the way. Mm-hmm. And that's one of the things I tell everyone at the start. You got to get the competition and finances away from the table. Because then it doesn't make any difference to you, but that's not a driver. And then after you start that, then I believe that what you then have to have are individuals that are willing to change. Mm-hmm. I mean, we get set in doing things the older we get, and we think it's really a great way to do it. My brother's a cardiothoracic surgeon, Jimmy, my oldest brother, and he's an adult cardiothoracic surgeon. So I very much know how surgeons think. Mm-hmm. And one of the things that I saw in congenital heart disease, that over the years, our cardiac surgical colleagues, they really worked really hard on trying to develop techniques that ultimately gave a good outcome for a very complex problem. Mm-hmm. Transposition of the great arteries. Started with a mustard atrials, and then they go to an arterial switch. When they were doing well with the other, mm-hmm. but they said, they're not doing well in adulthood, so we got to switch, we got to change. They went back to an old idea that failed, and then made it successful. But they had to take their lumps along the way with a higher risk for the patient. But they knew that was better. Once they've mastered that, they're not going to be that reluctant to change again to do something different. It's the same thing as we talk about hypoplastic left heart syndrome. Once they master a very difficult procedure, difficult way to take care of babies, why should I change?
Well, that's certainly something that I hear all the time is, our surgical center has these results.
Right.
How can we improve on these results, and why should we take that risk? And I think that has been a barrier, I think, to some extent in terms of trying to advance these kinds of relationships and really a theory of how one should approach the patient.
Yeah, I used the two examples for a specific reason. I used the transposition of the great artery patients as the first example. It's because the surgeons were being told, you know what, after the Senning operation or mustard operation where you're doing the atrial baffle repair, you get the mortality, morbidity way down. But you know what? When they come back, they have arrhythmias and their function's bad and their things. So when they get older, they're not that great. So the surgeons got thrown back in their lap. Look, isn't there a better way to make the arrhythmias maybe better, make the function better long term? Because it's not just about getting survivors; it's long term. And they changed. Okay, now let's throw it to hypoplast. Babies with hypoplastic left heart syndrome, the 100% mortality without any therapy. And so the surgeons, once they mastered this very difficult thing, and they say, God, our results are really great. But what everybody's telling them is, they are and they're surviving, but if you look at their neurodevelopmental outcome, if you look at also how they are down the road, is this the best we can do? And is there a potential, another way that might get a long-term outcome? That's what kind of pushed us. Mark pushed this project for hypoplastic left heart syndrome in doing the hybrid stage 1. He came from Columbia with Dr. Quagenborg. Excellent results in the conventional surgery. He says, we may be reached as good as we can get right now as far as mortality survival. But we can't be satisfied with the ultimate outcome in these babies. It's the worst neurodevelopmental outcome of any congenital heart disease there is. And so he says, maybe there's a different way we should think about this. Maybe we shouldn't put them under bypass and cardioplegia when they're little babies. Maybe that's going to make an impact. And so he was the one kind of thinking about those things, and he happened to meet a guy like me and says, yeah, I'll do that. And that's really what it came to. I think it's on both sides. You have to throw out to both services. Are we satisfied with the ultimate outcome, not the immediate outcome, the ultimate? And changes were made because of that earlier in surgical history.
And I certainly think that is some of the challenge in the thinking is that we get so used to thinking about immediate procedural operative successes that sometimes we need to refocus on what really the year 1, year 2, decade 2, decade 3, what's really going to be happening for the patient overall. And I think that the strategies that you've developed and the thinking and the vision has actually been pretty tremendous.
And one of the things I was going to say is that one of the big positives out of this is not just the specific project. It's really the attitude of all the individuals, that all of a sudden another unrelated problem surfaces and says, would you come in here and maybe look at this, and let's look at this together, and maybe there's a way we can do this together, and that led us to intraoperative stenting, and that led us to here, and that. And all of a sudden, there are just almost these issues that we're doing in valves, transcatheter valves right now, and we're putting them in when they couldn't be placed the way that they were supposed to. We're having our surgical colleagues help us with it. So I think that this is just it opens up so many areas of avenues. And I think that the other thing it does is because we deal with people that have congenital heart disease, no matter how big, old, or small, and large you are. So we'll have babies that are 500 grams. We'll have people that are 70 years old. We have to figure out a better way to take care of those. And I think combined therapy is probably the way.
That one of the things that you pointed out today is not so much where you're doing it, it's the mindset of how you're doing it. And I'm wondering if you might expound on that a little bit. Certainly there are certain things that make your job easier.
Yes.
But it's not necessarily that everybody has to have 5 new cath labs.
Our probably manufacturing colleagues would probably not necessarily want to hear this because, the big push in all of cardiovascular medicine, not just congenital heart disease, is our hybrid labs in which you have imaging in the surgical suite, particularly. The vascular surgeons need this for their grafts, and The cardiothoracic surgeons need it for other things. Now the TAVI programs, and they need it for that. So, I mean, everybody wants it, and it's going to be necessary for certain things. But you're right. We started in just a plain facility, and just said, how can we? What can we do to do the procedure we think is the right procedure to do, and how can we do that? And we just started, like the American ingenuity, just improvising and saying, well, if I use this equipment and if I use this, we can do this. Now, like you said, having it all designed exactly with the way you want and all of your colleagues want. The echocardiographers want to be a certain place. The anesthesiologists want to be a certain. You get input from everyone, and you have everybody have a stake in the facility. But it's not necessary to do the procedure. I didn't show two slides that I usually show during a hybrid talk. One was a quote from Evan Zahn at Miami Children's Hospital, and he said it was a long quote. It was like 3 paragraphs, but in the end he says, I'm not sure what to call it. We weren't smart enough to coin the word hybrid back then, but we've been working in the early post-op interventions and all kinds of things that they've been working with the group there at Miami Children's and Redmond Burke, the surgeon, and he says, and I don't know what to call it other than it's just a collaboration. That's all it is. You don't have to have a special facility. You just have to have a collaborative spirit. And then Mark, in one line, says the hybrid therapy is all about collaboration. That's all it is. So I think that the suites are very nice. You can do things much easier. I think in the future they're going to be probably more of a prerequisite because we're going to start doing procedures that are really going to be dependent on the suite. But it starts. Another way to do it. We had many individuals, institutions visit our labs, our hybrid suites. I want to build it. We had some that went out and built it immediately. Didn't do a case of a hybrid procedure for over a year because they still didn't have the collaboration. Right. They had all this beautiful facility, but they still didn't believe in working together yet. So you can't build it and they will come. Right. Type of thing. You got to have the guys that want to do it, people that want to do it, and then utilize the facility. Right.
We're oftentimes faced a little bit with a quandary because there's very little that's actually really designed specifically for us, and so I think that this has certainly resulted in people like you having the wider view and the wider focus, directed focus, that's been really tremendous in terms of innovation. Well, one other question I was going to ask you is in terms of adults with congenital heart disease and those hybrid interventions. What's the future of that?
Well, the adults with congenital heart disease, I think that what we're going to see is that the principal problems that adults have as they age with congenital heart disease, they have heart failure, they have arrhythmias, they have a lot of valve problems. Whether they didn't have the right valve in the first place or we gave them an artificial valve for a while that wears out. So those are the major conditions we're going to be faced with dealing with. And I think that it's clear that while there are strictly surgical options for some of those, strictly medical options, and strictly catheter-based options, I believe in the future that we're going to see, again with the assistance of our surgeons, we're going to see valves replaced, repaired through a combination of a hybrid, of a catheter surgical based off bypass. I mean, we're already seeing it with the TAVI programs now, the transcatheter valve, but that's the gateway to the mitral valve, that's the gateway to the other valves, and it's a direct access, and we don't have to rely on whether we go here and go through curves and stuff. I really think that the valve therapy is going to be through this access in the future. It's just too easy, and you're in a situation where if you need to make surgical modifications at that time, you're there. So I really think valve therapies are going to be all by this method in the future.
Okay. Well, John, I really want to thank you for your time today. Certainly, it's been a pleasure listening to you talk today. And certainly, I think that we all realize the huge impact that Chuck Mullins has made to our field. And I think that it was a fantastic way to continue his legacy. So thank you very much for spending time with us.
Thanks, Dennis.